Visit licensuraexams.com and try our samples completely free of charge.
Well, hi, everybody, including you people up there in the freezing north. I'm looking in the old mailbag, and Sandy from Albion, Michigan, asked for information that would be useful for the licensing exam about panic disorder. Hi, my name's Eric Twachtman.
And I'm Dr. Linton Hutchinson. Today, we're going to focus on the complexities, the diagnosis, and treatment approaches of panic disorder.
And let's start by clarifying what makes panic disorder distinct. Can you break it down for us?
Sure. So when we look at panic disorder, we're seeing reoccurring, unexpected panic attacks paired with persistent worry about future attacks. What makes this condition unique is the behavioral changes that occur in response to those attacks.
Right, you are. Panic attacks tend to hit suddenly and intensely, unlike anxiety, which tends to build gradually. And they either occur without any noticeable trigger or by specific situations.
Well, I'm interested in how the different types of attacks that a client has are categorized.
Well, there are three main types.
Yeah.
First, the unexpected attacks, like I mentioned, that come without warning. Then you have situationally bound attacks, which consistently occur in specific situations. And the third type is situationally predisposed attack, where exposure to a trigger might lead to an attack, but it might not.
So it's the unpredictability that often leads to significant changes in their behavior. A client might start avoiding places where they had attacks before, or situations where they worry that help won't be available.
Yes, which makes it so that clients often create elaborate avoidance strategies, taking a longer route to work, refusing to eat in certain restaurants, avoiding exercise, which might increase their heart rate. These changes can seriously impact their work, relationships, basically their overall quality of life.
Wow, I had something like that happen to me. I was in Publix right down the street, and they ran out of kimchi that I really like. I ended up going to another store farther away just to avoid feeling disappointed.
Well, what a stressful situation that must have been, but I don't think that's exactly the same thing, is it?
Maybe not. What are the specific criteria for diagnosing panic attacks?
Well, according to the DSM, diagnosis requires recurrent, unexpected panic attacks followed by at least 1 month of either persistent concern about additional attacks or significant behavioral changes. And during the attacks, a client needs to experience 4 or more specific symptoms.
And that can manifest as both physical and cognitive. Physical symptoms include sweating, trembling, shortness of breath, and chest pains. Cognitive symptoms include derealization, fear of losing control, and fear of dying. Some of them sound like they could be symptoms of other disorders. So, what are the differentials?
Well, several anxiety disorders, including ones that are substance-related and medical condition-related anxiety disorders, are differential. The key is the sudden onset and intensity. Unlike anxiety, these symptoms peak within minutes and often feel overwhelming to the client in that short period of time. So it's important to rule out the medical conditions and substance-related causes. At its core, panic disorder involves a fear of fear itself.
Wasn't that what Churchill said during the Second World War?
Close. I think you're thinking about our president, Franklin Delano Roosevelt, who said those exact words. But he wasn't talking about this disorder. He was talking about the Great Depression. A client develops hypersensitivity to bodily sensation and their interpretation. That creates what's known as the fear response cascade. And how would you explain that to a client?
I guess I just wouldn't. They just have to take it on faith.
You're on your own.
No, actually, I'd use some clear examples. They would notice that their heartbeat is slightly faster. They would interpret this as a sign of an impeding heart attack. And then this interpretation would trigger more anxiety, which then again increases physical symptoms like rapid heartbeat and shortness of breath. What approach would you use to break this cycle as?
Well, the best thing to do would be to focus on helping clients recognize the pattern as it's happening and to work on reframing those initial interpretations and developing a more balanced response to physical sensations.
So you're saying you would intentionally try to have your client have a full-blown panic attack during sessions.
That's right, just for fun. No, of course not. But eventually you would work up to it. It's called in vivo desensitization. You go
Ah,
gradually, but we'll talk about that more later.
okay, that sounds like a plan. With panic disorder, accurate assessment is very important. Let's go over some assessment tools that have been found to be effective.
And that you might see on the exam, right?
Right, right.
One is the Panic Disorder Severity Scale, which is widely used. It helps measure attack frequency, distress levels, various types of impairment, and it looks at 7 key areas: frequency of attacks, associated distress, anticipatory anxiety, agoraphobic fear, interoceptive fear, and both work and social impairment.
Man, you can tell that was written by a psychologist, can't you?
Yes, you can.
There's also the Anxiety Sensitivity Index and the Body Sensation Questionnaire. The ASI gives us insight into how clients interpret and respond to anxiety-related physical symptoms. It measures fears about physical concerns, mental incapacitation, and social evaluation. The BSQ helps identify which body sensations trigger the most fear.
And the mobility inventory for agoraphobia is used to track changes in avoidance patterns, and the agoraphobic conditions questionnaire is for mapping out catastrophic thinking patterns.
And don't forget the Albany Panic and Phobia Questionnaire that is useful for identifying specific activities that produce sensations similar to panic attacks. This helps guide the client's exposure hierarchy. And for the exam, you see that all of these assessments, or at least most of them, have the word panic in them. So it will be really obvious that you should select that on a question that is regarding assessments.
That's right. They either have the word panic or agoraphobic, which, is part of that whole process.
Yeah.
Some of these comprehensive assessments are to be used at intake, some used as a follow up at regular intervals to track progress and adjust treatment plans accordingly. Then, panic attack records are reviewed weekly to identify any emerging patterns or triggers.
That sounds like a good transition to review some effective treatment approaches that might be on your licensing exam regarding panic disorder.
Well, you might start with psychoeducation about the nature of panic and the fight or flight response, and then move into cognitive restructuring and some breathing techniques. Then spend significant time mapping out the client's specific panic cycle, identifying their unique triggers, sensations, thoughts, and behaviors.
Okay. For those of you that believe in cognitive therapy, they
I'm a
tend to
believer.
focus. What?
I'm a believer.
Okay. That will tend to focus on helping clients identifying and changing their catastrophic thoughts, and also work on developing alternative interpretations of body sensations. Thought records are particularly useful, especially when tracking the intensity of beliefs before and after restructuring.
And another technique is with interoceptive exposure. That is, controlled exercises that safely reproduce feared situations, like we were talking about before. This could involve having clients run in place to increase their heart rate, breathe through a straw to create mild breathlessness, or spin in a chair to induce dizziness, then gradually progress to in vivo exposure out in the world, always moving at a pace that feels challenging but manageable for the client.
Right. And you mentioned breathing techniques.
That's right. It turns out that overbreathing can create many of the sensations that clients fear, like lightheadedness and tingling. The client will practice diaphragmatic breathing first in a calm state than during mild anxiety.
Mhm. Progressive muscle relaxation and mindful body scanning have been particularly useful. There's a long form and an abbreviated version. So, what are some challenges that therapists would see when treating panic disorder?
Well, one frequent challenge is the client's reluctance to give up the safety behaviors that will actually help them. They often have elaborate systems of coping, like we talked about driving way out of your way to go to work, or anything that they feel is protecting them, but that actually maintain and reinforce the anxiety.
I see that. Yeah. There's also medical reassurance seeking. That's another common issue. Clients often get caught in the cycle of repeated medical tests and going to the emergency room every time that they have a panic attack. Those are the bare facts. And I think it's time for a quick knowledge check. Which of the following is not required for diagnosing panic disorder according to the DSM?
Oh, the old not question. Okay, shoot.
All right. A, recurrent unexpected panic attacks. B, 1 month of persistent concern about future attacks. C, present of at least 3 physical symptoms during attacks. Or D, significant maladaptive behavioral changes related to those attacks.
Oh, so you didn't think I was listening to what I just said a few minutes ago. The correct answer is C, Linton. The DSM requires 4 or more symptoms
Okay,
during panic attacks,
4. I
not
got it.
3.
I got it. Mm-hmm.
This is an important distinction for accurate diagnosis and one that you might see on the test, just like you said. Now
Yeah.
I have one. Which
Okay.
of the following is not a prognostic factor for panic disorder? A, temperamental. B, environmental. C, genetic. D, employment.
Well, I'm not sure what temperamental means.
Well, you've been that way, so you should know.
Okay. Environmental, genetic, or employment? Hard choices, but I'm going to say D, unemployment. Not unemployment, but employment.
Yeah, well, we've all been there.
Yeah. Well, if you've seen some of the jobs I've done over the years, you would have to have me as a prime candidate for panic disorder, especially at the disco.
Yes, of course.
Any final thoughts about our topic, Ez?
Yes, remember when you're taking the licensure exam that each narrative subject's experience with panic is going to be unique. So your response needs to take that into account. But as we always say,
It's in there.
Absolutely. Thank you all for listening.
Okay. See you later, Ez.
Ciao.